Hello. Just to say that nearly 20 years ago, I worked in Melbourne for a year when I was a graduate as a veterinarian. Little did I know that nearly 20 years later, I would be in northern rural Malawi trying to quantify the burden of stroke. So to start, I think I'll give you a little bit of background about Malawi. In terms of Malawi's position in the world, we're in the southern part of Africa, and we're bordered by Mozambique on the coast, and inland Zambia, and to the north, Tanzania. It's a very poor country. It definitely qualifies as a low-income country, possibly in the bottom 5 poorest countries in the world. And in our setting, healthcare is very constrained, and we have very few medical practitioners in the country, and you can see that the ratio of doctor to patient is very, very different to what we would enjoy in Australia. So in terms of where I work and where the surveillance for stroke is going on, it's in the very north of the country. Actually, I should have shown that more clearly. You see the yellow boxes. We're right up in the north, close to Tanzania. And we cover an area of 135 square kilometres. Our population is 40,000, and roughly half of those people are under the age of 15, so very high total fertility, around 5.6. We run a demographic surveillance site. For those who aren't aware of what that really means, it's a way of capturing information about the population in a setting where there are no vital registrations, so people's births and deaths are not recorded in Malawi, unlike in Australia. And so we work very closely with 300 respected community informants to collect information on births, deaths, and migrations. And what it allows us to do is to quantify the burden of disease within our population, because it provides us with a denominator for calculating rates. We also nest within the population various studies looking at different types of disease, most notably HIV, TB, and more recently, non-communicable diseases. So this gives you an idea of our age distribution and how it compares to Australia. We're a very, very young population, but it is an aging population because since the rollout of antiretroviral treatment in our population in 2005, we've seen considerable gains in life expectancy in HIV-positive people, and now the life expectancy is matching what is observed in HIV-negative people, although we aren't seeing gains in life expectancy among the HIV-negative people. So in terms of the cause of death in our population, we are able to get a rough idea of this because we do verbal autopsies. So about a month after a person dies and that death has been reported to us, a medical interviewer will visit a household and interview the carer of the deceased. And so we're able to get a rough idea of the cause of death, and looking most broadly but at communicable and non-communicable diseases as the cause, we can see that over time, communicable diseases as a cause of death have reduced greatly as a result of widespread free antiretroviral treatment, and now non-communicable diseases are the leading cause of death in our population. So a few years ago, I got a little bit interested in looking at this a bit more and started to wonder, well, what are the sort of more specific causes of death? What would they likely be in our setting? And I started looking at the VA narratives and the sort of underlying signs and symptoms that were allocated to deaths, and we could see that actually stroke was second to HIV as the cause of death among adults. And this actually fits in quite nicely with work that has been going on in the past few years. Between 2013 and 2015, we did a prevalence survey for non-communicable disease in our setting. Now, a lot of WHO NCD step surveys have been done across Africa, and you can find them on the WHO website. There's about 41 in Africa alone. And we decided in Malawi that we would do quite a large survey, and this is possibly the largest survey to date in sub-Saharan Africa. We were able to recruit around 29,000 people aged 18 and above. And you can see there that I've presented the findings by age 18 and above, and in parentheses, those for 50 years and above. And you can see that we have actually, especially among women in the urban setting, quite high rates of, or high prevalence, of obesity, overweight, and particularly also high hypertension prevalence in the urban setting in both men and women. And with this information in the background, it became increasingly important to start considering, well, what is the underlying cardiovascular disease risk in our population, and are people actually experiencing myocardial infarction, strokes? And so I started to think about how we could go about quantifying that burden of stroke and capturing incident strokes in our population. In terms of background information on stroke incidence in southern Africa, there's very little data. Richard Walker is a professor based in Newcastle. He did a stroke surveillance project in the early 2000s in Tanzania called the Tanzania Stroke Incidence Project, in an urban and a rural demographic surveillance site. And he found that the stroke incidence in people in the urban setting in Dar es Salaam had rates similar to what was observed in African origin Americans, and those rates were 3 times higher than what was observed in the rural setting. So Salim Youssef has done a large study across 22 countries, including 3 countries from sub-Saharan Africa, looking at stroke patients that are attending hospitals. Now, clearly that doesn't, in our setting in Africa, represent the community, because access to care is quite limited in some settings. But he found that nearly 35% of stroke risk is attributable to hypertension. Now, there's very, very little information on transient ischemic attack, which is a mini stroke. It lasts for less than 24 hours. And we wondered whether, if we were going to try and quantify strokes in our setting, could we try and also capture information on TIA as well? So this project, bearing in mind that the population is 20,000 adults, it's small, and thinking about the fact that stroke is actually a rare event, the numbers are going to be small. But we still thought, let's see what we can find out, because there are a lot of demographic surveillance sites across sub-Saharan Africa. And if we can start to quantify this burden and get an idea in our setting, perhaps there's scope to do more of this sort of work in other settings and look at trends over time. So the main aims were, let's quantify the burden of stroke, see if we can capture information also about the incidence of TIA, and also let's see if we can understand a little bit about what people's knowledge and perceptions of stroke are in the community as well. So the work was started in 2015, and this was something that I was able to implement quite rapidly in our setting, because I had been working there since 2011 on various HIV-related projects. So we have a nice relationship with the elders in the community, and they were very interested in learning about stroke, particularly as it was something that they felt was relevant to their own health. So we trained them in the FAST symptoms, which is face droop, arm weakness, leg weakness, speech difficulties, and to seek help as soon as possible. We translated this all into the local Chitombuka language, and we provided those informants with mobile telephones and solar chargers, so that should they find someone within the 30 or 40 households that they care for having any symptoms, signs that look like stroke, then they should call us. And it was an interesting experience, because of these 300 informants, about 30% of them had never owned a mobile phone before, so there was a lot of sort of training in terms of background technology as well. So the stroke surveillance looks a little like this. A person has a stroke, the informant in the community would contact us, and our medical assistant would go out to a household on a motorbike equipped with a blood pressure monitor, an ECG, various medications for treatment of high blood pressure, aspirin, and a glucometer, and a stethoscope, and various sort of basic medical equipment to try to do a rapid assessment of a stroke patient in their household, and to see, do they think that the person has had a stroke, and if so, to refer them into care as soon as possible to the hospital. The medical, the staff on the project, on the study also would visit the hospitals in the area. There are four rural clinics in our demographic surveillance site. They'd visit twice a week to look through registers also discuss with the nursing staff and the clinical officers as to whether there had been anyone who'd come in, was currently admitted or had been discharged with a stroke, and then they would follow up accordingly, so that we would get stroke surveillance complete across the community. So while the stroke surveillance was going on, starting in 2015, we decided to do a cross-sectional evaluation of knowledge and perceptions. And this sort of work is being done quite a lot. There's quite a number of studies done in Africa and lots of studies in more developed settings as well. So we use those data to try and inform how we would approach our own sort of interrogation of these questions around what is the knowledge of signs, of risk factors, and how to treat somebody who has had a stroke. And interestingly, in our setting, there is no Tombuka word for stroke. The actual literal translation is body part not working. So we didn't use that, obviously, because in terms of when we asked them whether they knew what a stroke was, because that's actually what the term is called when they go into a medical facility with signs of a stroke. So we aim to recruit about 840 subjects to the study, selected across the entire DSS, stratified by age, across each of the smaller regions within our surveillance area. And we found that we had very high participation rates, which we were quite surprised by. It was an interviewer-led, open-ended questionnaires, and those were then double-entered into an Epidata software. And overall, we found actually that the community had really poor knowledge. We'd hoped to quantify an outcome as having good versus poor knowledge based on what other studies had done, having 4 or more sort of correct responses. But we found actually most people couldn't come up with, either any responses or maybe one response, correct response. And so we ended up having, it was either some response or no response, which was interesting in itself. And we also found that a lot of 20% of people thought witchcraft was actually an important cause, and that hypertension was also an important underlying risk factor for stroke. So this background little study turned out to be quite interesting, because it really told us that actually people really don't know a lot about stroke. But interestingly, once we explained to them what stroke meant in local language, that it's body part not working, the majority of people, over 80%, did say that they would take the person to a health centre. So it didn't appear that the idea that witchcraft might be involved would be a deterrent for taking the patient into care. So looking now at the first 2 years of surveillance, we've been able to actually do the work, which has been a great sort of proof of like a concept, and that it's possible to do stroke surveillance in a very resource-constrained setting. And I might add that we are 700 kilometres from a tertiary facility. There is no access to advanced neuroimaging, and our local hospitals are very, very rudimentary facilities. They're not equipped with any surgical theatres, and at most they have beds for maternity and a small pharmacy. So the preliminary data that I have so far is that we're getting quite a lot of notifications from our informants, and we've had 109 over the past 2 years. About 50 odd of those are from the informants we trained. Nearly 20% are from actually other staff members on our project who have also been trained, which is very useful. We've found 50 strokes, and we query 14 TIAs, and obviously we can't be sure of any of these, and they are stroke-like events, because they are not confirmed with advanced neuroimaging. Almost half of those those strokes that we've captured were notified within 24. They were notified to the informant with 24 hours of onset of symptoms, which was really surprising to us that the actual surveillance was operating in real time in such an effective, efficient sort of way. The crude stroke incidence that we can calculate, it has wide confidence intervals on this. I think the upper confidence interval goes up to about 2.9. It's 1.5 per thousand, or 150 per 100,000. So this is a crude estimate. Now, I haven't age standardized this, and it's something I would like to do in time. I've looked at doing it. It looks a little strange because we don't have numbers in lots of the age bands, but it looks like it's getting up sort of well over it's about 3.8, close to 4. But again, these are small numbers so far, and I don't want to interpret what we're finding. But I will say that strokes happen in our setting, and it is not a rare event in Malawi. We also found that actually we're seeing comparable mortality within 30 days as to similar to what is seen in the UK, although slightly higher. We haven't seen many TIAs going on to strokes, and certainly as yet we haven't really seen that many, actually there hasn't been any recurrent strokes in our setting. What we do see that is quite it's a very important thing, and we see this by going to the households. We see them the patients at a week, 1 month, 3 months, 6 months, 12 months, is that all of the care provided to stroke patients, the post-stroke care, is provided by family members. There's no physiotherapy, occupational therapy, speech therapy, and no nutritional support. And one of the really striking things was seeing these very vulnerable people declining because they weren't actually able to get adequate nutrition or adequate physical therapy. And so as part of what we're offering to these patients now, we are actually providing some level of training in physiotherapy, basic physiotherapy, to the care providers. This is just some characteristics of the stroke patients. You'll see also I've got QEH. QEH is the Queen Elizabeth Hospital in Lilongwe, where a study was done by Laura Benjamin on hospital-based stroke patients, and she had access to an MRI scanner, one of 2 in our country. And I've put that up there just to compare what Laura found in a hospital, tertiary hospital in the south of the country, to what we're finding in a rural setting where we don't have access to an MRI, obviously, or a tertiary hospital. But the most notable thing is that Laura has published her findings, and she found that HIV was a very important risk factor, especially in young stroke patients under the age of 45. But you can see there that only 10% of our stroke patients are HIV positive, and it's all in our setting. We're finding that the stroke patients are older people, and there's not the overlap at this stage with the younger people who are HIV positive. And we are finding that the majority of people are seeking medical care at some point after having a stroke, and at least half of them are seeking care within 24 hours of onset of stroke symptoms. So here's just to show a little bit of information about those sort of background risk factors. I haven't bothered to look at this in any kind of detail with statistics because I have 50 events. But this is going to be hopefully ongoing work. We hope to continue the stroke surveillance nested within our demographic surveillance on an ongoing basis. So we'll be able to look at these data in more detail over time. But you can see that hypertension is highly prevalent in our stroke patients. You can see those with a prior diagnosis is close to 70%, and over 50% are on treatment. That treatment and the diagnosis has largely come about as a result of the prevalence survey we did in the community, because across the community there's very little treatment available for hypertension. It's provided by the London School of Hygiene because of the prevalence survey that we did. You will also see that 30% of the stroke patients are actually either overweight or obese. So in terms of these findings, I keep sort of saying they're small numbers. I guess it qualifies as a pilot piece of work. We can do it. We can see that strokes are happening. We can't obviously differentiate whether these are stroke or stroke-like events, stroke mimics, but we do our best by trying to exclude other possible causes. We test for syphilis, toxoplasmosis. We check for underlying TB if patients are symptomatic. We check the young patients for sickle cell. So we do the best we can. We check for underlying diabetes, hypertension, and so we try to be as confident as we can with our clinical diagnosis. There's obviously the possibility that we're missing patients who leave because they're sick prior to having a stroke and they leave the community to go elsewhere where there's better health care. And it's also possible that we miss sudden deaths due to stroke because perhaps our instrument for VA is not sensitive enough to establish those as strokes, as a death, and that I need to do more work to triangulate the narratives and the verbal autopsies to establish whether we're complete in capturing those. So in summary, stroke isn't uncommon in Malawi. Our population has a very, very poor understanding of stroke signs and underlying risk factors. Hypertension is very prevalent both in the community and among our stroke patients. And strokes are happening in older people, and it's not in the young HIV positive people, and it's in older people who have very typical NCD risk profiles in our setting. So in terms of the public health implications of our findings, we can see that a lot of the deaths that are happening, they're premature deaths. These are not really old people. These are people under the age of 75. And the majority of the strokes are not fatal, so there's a burden in the community, and that burden is being met by family members, and they don't receive any support. There's a real need at national level to try to address the understanding of stroke and cardiovascular disease in the population in Malawi, and there's a need for service provision for prevention and treatment of stroke, hypertension care, which really does not exist at a national level in our setting. So I'd just like to thank the Wellcome Trust, who fund this little bit of work that I'm doing, and for the supervision that I received from Valerie and from Moffat Urenda, Mia Crampon, Richard Walker, who did the work in Tanzania, and Liam Smith from the London School. Thank you.
Thanks, Stevie. Thanks.